All right. I'm Whitney. I'm really excited to come and talk today. I get to brag up the facility that I work with, which is something I love to take every opportunity to do. I work at Family Health Care, specifically in the homeless health program at Family Health Care. We're an FQHC. We're the only national health care for the homeless grantee clinic in the state of North Dakota. We're a level 3 patient-centered medical home. We have a whole bunch of services, newest ones being hepatitis C clinic, medication-assisted treatment program with Suboxone, and upcoming behavioral health. We have 2 counselors right now. And it's a little dear to me, behavioral health, because I'll be filling the position of the prescriber in a few months when I finish school. So when I was trying to think of how I was going to talk about family health care and what I do, I wanted to kind of tell you guys what family health care and this work feels like to me and let you guys just read the statistics, because you can read, I hope. I shouldn't assume. But anyway, so family health care, I love that we got the patient-centered medical home status, because it does feel like a home to me and always has since I walked through the doors about 5 years ago. I'm proud to say my own family receives health care from Family Health Care, and we do pretty awesome work. So what do? I don't even know what my job description is now, because it's really changes from day to day. I provide complex care management because we are like limited resources. In the state and within agencies, we do a lot of collaborating teamwork with other agencies outside of our organization. But I always base interventions on the individual goals of the patient. Most of our interventions actually in homeless health are mostly based in harm reduction rather than, I guess, the traditional interventions. We are trauma-informed, so we try to work from that. A lot of our patients have experienced traumatic events. And we really work on building those partnerships up with other agencies, and I think we have great teamwork in our community. We try to build community awareness as well. So this is an official thing. This is what I kind of formulated through digging through our chart data as being the highest rates of morbidity and mortality in North Dakota, the top 3. So ACEs, which are the adverse childhood experiences, is a product of one of the most robust qualitative studies of the past 50 years, and I feel like we're just getting to them. We know that they contribute to illnesses that have some of the highest rates of morbidity and mortality, but we don't use them enough, because if we did, we would be moving more towards trauma-informed care models. So I kind of want to share, I guess, secrets of how to make your own healthcare center a home, whether it's a clinic, a hospital. And the first step to homemaking, I feel like, is not to take everything so personally. Just be present, be genuine, be empathetic with people, and try to think of really put yourself in the person's situation and try to give them the benefit of the doubt that they're not personally attacking you by being rude or short. And just try to think instead what could be causing this behavior, rather than how dare they, I'm going to call the cops. So Native Americans have the poorest health status in North Dakota. As you can see, we live about 20 years less than the general population in North Dakota. I say we because I'm Native American. Hard to believe. I left my headdress at home, so it's hard to tell from my appearance. And that's not just true for North Dakota, it's also true in South Dakota and probably at least another dozen states. And I want to know, whenever I hear about measures to try to increase like diversity in nursing or in other healthcare fields, I want to know, how can a kid on the reservation in North Dakota who can live to be 54 years old is supposed to even start to imagine attending college? And then from there, even imagine getting a master's or a doctorate degree, that wasn't in my head whenever I was a little kid growing up on the reservation. I didn't even think that I was going to go to college. I almost dropped out of high school. At one point, my GPA was half, 0.5. But I was lucky. I had family and mentors that built me up and encouraged me to do what I wanted to do. Some stuff that I didn't get put on here because it was sort of, I kind of thought of it afterward, is also something that's become a big topic of conversation is the violence against Native American women nationwide. And North Dakota is not an exemption. In 2016, only 116 of 5,712 cases of missing Indigenous women or girls were logged in the Department of Justice database. And the median age of when those women and girls were murdered or went missing was 29 years old. So the second step to building your home is to keep in mind that people with lived experience are a valuable asset. Empower them. Family health care is built on compassion driven by people who have firsthand experience. We have excellent interpreters that are former refugees themselves. So when our refugee families walk through the door, they're being met by somebody who has the exact same life experience as they do. They remember what it was like to walk into the airport at Fargo Hector International Airport with that IOM bag and think, what's next? What's going to happen to me next? And they really, that's what makes our facility so unique. Some interventions that, and I say community-wide, Family Healthcare actually had me do a training on Native American culture at one of our all-staff meetings. These are some other community things that we've done. I had a great time with being able to offer clinical experiences to NDSU nursing students. I think they were really surprised. We went to a powwow. I took them to a powwow. And I told them they weren't going to do any blood pressures or anything like that because I would hope that they were competent in that because they were senior nursing students. Instead, I had them just talk to people. Just talk to people, build a relationship with them. None of these people trust you, any of you. They have no reason to, so give them a reason. And give them a reason to, when they see an NDSU nursing student and when they're in the hospital or clinic, or they know a nurse went to NDSU, they think, I remember that school does a good job of telling people how to take care of us. And that's the way to decreasing the tensions that exist in North Dakota, because there is a lot of tension between Native American people and non-Native people in North Dakota. The LGBTQ community, this population is super at risk within the homeless population. They have the highest rate of death of anybody experiencing homelessness. The youth do, and that those deaths are typically caused by violence or suicide. I don't have the personal firsthand experience of living as a person in this community, but I take it upon myself, which every professional should, to find those people in our communities and educate yourself. Because if I can, you can too. Everybody can. We can take that time, we can do that. So we are required by CMS at Family Healthcare to collect demographic information that includes sexual orientation, gender identity, and it was suggested at first that the front desk could do it. We actually moved those questions to being a nursing intervention that's performed by the rooming nurse, and it's introduced in a way that is makes the patient feel like they're safe to divulge information. It's saying this is as part of your treatment plan. The provider honestly isn't going to treat you any differently based on your answers. Just kind of want to design care the way that it should be for you, and certainly that's something that's probably very important to you. So women in North Dakota, domestic violence, incarceration, and human trafficking are three of the biggest threats to women in North Dakota. Human trafficking came to our front doors about 2 years ago, and we took it head on. we had some training done by a local entity, and I really pushed myself to be more involved in community efforts to combat that. And we now have the human trafficking screening tool developed by the Human Trafficking Task Force in North Dakota in all of our exam rooms so that our providers can conduct those assessments when they're thought to be important. And one of my friends that I work with on things posted something last night. He's pretty cool. I'll talk about him a little bit. He's a felon himself, and he has started a housing program and a peer support program for felons called F5 Project. And anyway, he had posted online last night, and when they took a look at stuff, in 2018, the U.S. had the highest rate of incarceration in the world, with 737 prisoners per 100,000 people. So I said we did that facility-wide training. But even before we had that, we had this really savvy nurse. One time we had a female come to the clinic, and she was, it appeared to be a very sketchy situation. The gentleman that was with her was doing most of the talking. And the nurse got him out of the room to the lobby to wait and asked her, "Do you want to be with him?" And she said no. She said, "Do you want me to get you somewhere safe?" And she said yes. And we did that for her that day. So I didn't want to run out of time before I got to this slide. So this is a picture of me with someone who is a shining example of what I've discussed. This was taken on what was just an awesome day for me. This is one of my patients. He gave me permission to use this picture. He and I presented together on a panel at a harm reduction conference, and he blew it away. He did such an amazing job. He was allowed the space to share his experience, what worked for him, what didn't. I got the opportunity to sit right next to him, but there was a whole row of people who had, at one time or another, provided service to him, and you could just tell just the pride radiating from them, like, yes, you're doing such an awesome job. And that empowerment is, I think should be part of medicine that is truly holistic, allowing people that space to share their experiences because it does matter. So we're a nurse and a patient in this picture. We're just two native kids from the res trying to make things work. Which, if he's watching, is probably making fun of how many times I said because he did the whole time during our presentation. He was counting them on his fingers right next to me, and I'm like... So the last step, remember that these are people, not projects. They're not just a study. If you can't take a study and put it into action and actually make a difference, don't do it at all. Because all those people see, coming from my point of view as somebody who lived in poverty, is that people turn you into a science experiment, but they really don't care what happens to you. Because if they did, they'd take that data and they would do something with it. I guess I would be so bold to say there's not enough being done for the example of Native American people. If we're still dying when we're 54 years old and everybody is living 20 years longer, then none of that data has gone far enough. So make sure that you're not trying to force people through broken or failed systems. Listen to them. Be that safe person. Be accepting. And that's how you become a home. Thank you.